I am so honored to be in the presence of my sisters. There's an old saying among the Luba tribe, and that is, the women hold the bottom and the top of the kingdom. I think that all we need is right here in this room. The answers are right here. So everyone knows that there's a movie coming out called Sex in the City. And we already got the permission from our sister from CDC to have sex, to enjoy it, and to even have a climax and be disease-free. So I'm going to talk to you a little bit about Sex in the City in New York City, and give you a little bit of background is that we are the Bureau of STI Control. We still put STD up there because we are funded directly from CDC. And we report to Kevin Fenton. So it's what he says right now. And in the Bureau, I am the Director of Outreach and Training. So I'm all over the city. And I also run the Syphilis Advisory Group because we had an outbreak of syphilis here in the city among men who have sex with men. So we formed a partnership with all of the agencies that primarily dealt with HIV. Understand this, STIs and HIV are one and the same. We should not separate them ever, ever again. It is a matter of dollars, and I don't think that we're ever going to see anyone walking around with a T-shirt that says, I'm part of the University of, my name is Lydia, and I have chlamydia. But we need to demystify it and take off the stigma so that people will access the services that they need. So let's jump right into it. I have a lot of the same data that my sister just presented. And so I'm not going to burden you with that, but I'm sure that everyone saw the New York Times, okay? Sex infections found in a quarter of teenage girls. And I don't want to spend too much time on this, but 1 in 4 age 14 to 19 in the U.S. has an STD. Well, here in New York, you know that we're also doing all of the school-based screening. And I'm sure that you all have seen those articles in the paper and what we're finding as we're going out to the schools and we do the education. We first give everyone basic STD 101. And then at the conclusion, we tell them if you've ever had sex, oral, anal, vaginally. If you came, because you see, sometimes they don't consider oral and anal sex sex. It's anything but that. And I say, did you come? And they go, I don't know. I'll say, okay, then you might want to test. Sometimes they don't even have a name for it, but they test and we're finding that they're positive and they had no symptoms. That's a very serious thing. So we look at today in New York City, 12 people will be diagnosed with AIDS. 10 will be black and Hispanic, and 3 will be females. So what is the message? We've been giving out condoms. How many people give out condoms in their agency? Raise your hands. And how many give out female condoms? And how many give out dental dams? And are you from all over the city? Raise your hands. You are. So what's our message if we're giving it out? We heard a little bit about disparities and the links as to why our women of color are still getting disproportionately infected. We know that STDs fall into the 2 categories of curable and non-curable, and we get this message across to everyone. And we normalize testing by saying you could have one of these bacterial STDs and it's treatable, it's curable. You could have come in contact with a virus and we treat the symptoms, we can't cure it. So we're getting the message out there about how to diagnose yourself if you see anything strange going on in your body. And then we're giving them testing, and we're giving them treatment, and we'd like to move towards giving them medication to give their partners. We can't do that. It is against the law right now, but those policy issues are being addressed right now at the state level. And that means where if you know you have something and you don't want us to contact your partner, this could be a person that if you're in a serial monogamous relationship, you're a little pissed off right now because you're in the clinic, but chances are in about 6 months, if the sex was good, you might go back and you don't want that person to reinfect you because they're loving you and they're loving somebody else too. So the best that we can do at this point is bring them into the clinic and treat them and anyone else that they've been with. So looking at our data here in New York City, this is 2005, and I'm going to move you up to where we are 2007 very quickly. But this is from our school-based screening project, and I believe that many of you saw these data in the New York Times and in the New York Post and the Daily News, and at the time we had just a little bit of funding, and it didn't come from CDC. It came from a small little grant, and we thought, let's just ask for it and see what we come up with. So this is what we found. In 2005, 38,971, almost 40,000. And look at who's infected. 15 to 19-year-olds, 20 to 24-year-olds. And many of them were asymptomatic. They did not even know that they had an infection, and they had gone on to another partner. 2006, we started beefing up the screening. We do urine-based screening at the health department, and we've partnered with many agencies. I don't know who's in the room, but some of you might have received direct funding from us to also offer urine-based screening on special occasions and at special like outreach events where you have large numbers of adolescents coming to those events. We give you the opportunity to offer them urine-based screening. Again, now 41,236, and we're still finding more and more cases of people that have chlamydia and they're asymptomatic. This is problematic. 2007, do you see? The numbers are getting larger. Now, we're still saying prevention. We're still giving out condoms. We're still telling people to come in. We're still telling people to use a dental dam, to use a female condom, to know what their partners are doing, to minimize the number of partners, but yet and still the numbers continue to rise. What's the message? There's a gap somewhere, and the data are proving that. Look at HIV diagnosis. This is among females in New York City. I am so glad that Samantha talked about neighborhoods, because that's what we're looking at now. There's a problem. If we are out there and we're on the forefront and agencies are out there and you're doing everything that you're funded to do and you're doing everything that you're passionate about doing to prevent the spread of disease, and you go back and the infection is getting larger, there's something else going on. And if you look at these neighborhoods, the dots, and I'm not even going to attempt to move this thing, I'm so scared. But the dots are neighborhoods where basically it is mostly African American and Latino, and we're looking at the High Bridge section, so that's that first dot way up there. We're looking at the Bronx. We're looking at Central Harlem, which is the lower section. If you go right over there by the water, that section is where you're connecting Central Harlem and the High Bridge, Morrisania section of the Bronx. Those are areas where there's predominantly African American, and once you cross the water, they're Latino, and they have a lot of housing projects. Well, the Bronx also has a prison. At one point, there were more prisons than schools in the area. There were very large schools, and when they didn't go to school, they took out a PENS petition. If they took out the PENS petition and the child did not follow the rules, they would wind up in the juvenile justice system. When they finish their little bit in Bridges, Crossroads, or Horizon, they go back to the same neighborhood. Now, we've trained them in the prison, but we didn't talk about prevention. We trained them how to be skilled in committing a new crime, and that crime carries with it disease. Let's look at HIV again, 2006. We're looking at the same neighborhoods: High Bridge, Morrisania, Central Harlem, East Harlem, Hunts Point, Crotona. These areas are very gentrified now. Am I correct? So people forget what happens with the undercurrent. When the tide comes in, it brings everything that's at the bottom with it, right? And when it goes out, it takes it back out. but then it comes back again in the same area, just a little further away. So you're taking people out, you make the neighborhood beautiful, but you have not renewed the mind. And you also didn't offer enough jobs, skills. So you brought them back into a pretty neighborhood where they're across the street from somebody in a luxury apartment, and they're still in the ghetto. I don't care how you gentrify it, it is the ghetto. And the behavior is the same. So females, why are we worried? You know, some people say, so why are we worried? So if a female does not get treated early, you see this whole thing about, you know, an infected area. So you get chlamydia or gonorrhea. It's untreated. Those are ascending infections. They work their way up into her reproductive organs. Now she develops pelvic inflammatory disease and or HIV. Now you're not only dealing with an infection, a new disease, but a mental health issue. It is traumatic not to be able to procreate. If that's what you want to do, and you find out later on that you can't do that. If you look at, this is Planned Parenthood, take a look at where the infertility rates are. I'm not going to burden you with that. Look at the neighborhoods where you have the highest number of infertile people and see if they don't match up with these neighborhoods that I just showed you the data on STDs and HIV. There is a link. What is our message? I'll give you some more data just to shock you a little bit. If we look at 2006 and we see, oh my God, 1,016 new HIV diagnoses. Now that's just the tip of the iceberg. When you look at these numbers, you got to figure that these are only women that are testing because of our outreach, because you're taking the testing outside of the clinic area and you want to normalize testing. And as you normalize it and make it part of everything else that we should be offering, because I'm an advocate for not just talking about sexual and reproductive health, but we are more than just the genitals. We are a whole person. Deal with our mental health, deal with our spiritual health, deal with our financial well-being, the whole person. So if we're just looking at this, we're looking at the tip of the iceberg because we did the little bit and we did the little testing out there and we're still finding more. 30,000, above 30,000 now, females living with HIV, and they're in the same neighborhoods that I showed you before. Central Harlem, East Harlem, Bed-Stuy, Fort Greene, Morrisania. The neighborhoods are the same. Again, to look at these data just says to us that we need to do more work. At one time, we were just thinking that it was just a certain type of person, that it was just someone that was using drugs, or they were the sex partner of someone that was using drugs. But if we look at how they self-identify as heterosexual, then why are we still finding 76% of these females are now getting infected and they're heterosexuals? So how are they having sex? Who are they having sex with? When are they testing? And are we getting them in time? Is our message too late? Is it too little, too late? And what is the message? It's a renewing of the mind. I'm not going to spend too much time on this, but our Caribbean born, we're talking to them a little bit too late. Now, some people say that they're coming into our country and they're infected. Can you prove that? You can't. What's to say that they weren't infected before or they got infected here? It doesn't matter. What came first, the chicken or the egg? It doesn't matter. It's interrupting the spread of further infection and enhancing the quality of someone's life, that we really need to focus on that. But I just want to show you that Caribbean, West African, West Indians, mostly people from the Côte d'Ivoire area, parts of Senegal, they're coming at Mali. Slowly we're seeing them come in. They're coming into agencies where they feel comfortable, where people can talk to them in their language and understand their culture and their religion. And religion plays a very key role in how they receive that information, how they process that information, and can they take it home and really talk about it in safety. That's an issue. But we're finding that 51% of the women from the Caribbean that are coming in are infected with both chlamydia, gonorrhea, and new HIV cases. We're finding now, let me just say this, a very small portion of syphilis. Everyone knows that syphilis is back, right? And the whole focus was on men who have sex with men, and not talking to women, understanding that every now and then, I don't care if those men say that they are gay or that they have sex or same gender loving, but sometimes they love a woman too. And now we are seeing women, young women, 14, 15, 16-year-olds coming in with primary and secondary syphilis, and they don't even know they have it. That's a serious issue. And they still won't tell you who their partners are. But we cluster. Just to explain this to you, even if you go to your private doctor, your doctor has to report that information to us at the health department. So we still get it, and it's our obligation to follow up and see who you had sex with and get them treated. Not that we want to know all the sordid stuff about what you did and how you did it. The bottom line is interrupting the spread of disease. So I'm not going to spend any more time on these data, but I want to say this. What is our message? We must target communities early, including outreach to women over 50. That's right, we have sex, and we get infected. Consider the mental health part of prevention and intervention strategies. Include that. Look at the effects of poverty and consider implementing skills building, employment training, target harm reduction and prevention to LGBT and questioning youth because they have sex with other people. And I get the high sign, but what should the message include? It's okay to wait. Abstinence is the safest method. You know, you still have to say that to people. And if you have sex, use a latex condom, dental dam every time because you don't know how they're having sex and who they're having sex with. Limit the number of partners. Always use contraception and understand that EC and birth control will not prevent an STI nor HIV. Get tested regularly. Harm reduction, talk to the doctors. We're out there, we're free. And then this. Talk about safer sex, then practice it. Tell your partner if you have symptoms. We need to get both males and females comfortable with the same person that you laid down with and you took your clothes off and you gave them the very, very, very best part of you. You need to make sure that they keep that part healthy because that gives you pleasure, that gives them pleasure, to empower someone with those. But again, consider the whole person. The mental health, the physical health, the spiritual side of that person, what drives them. I always tell young people when I go out and talk, you were destined for greatness. There's a purpose and there's a plan for your life. I don't care what has happened along your journey. This is a journey. We all make a mistake, but there's a purpose for you being here. Thank you.